The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. This is our FASMA webinar. To start off first, we're just going to do some educational stuff after the first informational portion of this today. It's come to the attention again that some people need some help with established outpatient visits. Again, in 2020, this is a good schematic diagram. We presented it before. It's in our 2016 information that we provided for FASMA webinars, and it's under the educational component. What's so important here is to understand that each E&M has a specific requirement for someone to have, for example, a level 4 visit here, 99214. They have to have a chief complaint with 4 history of present illness and 2 review systems relevant to the chief complaint and HPI reviewed. There's also supposed to be 1 past family surgical social history to meet the history component. To meet the exam component, the person must have 12 bullets and at least 2 systems in order to meet that requirement. And then the next component is the medical decision making. Of this, you need 2 of the 3 areas. These include the diagnosis, the data, and the risk. So for a level 4, for example, there has to be multiple diagnosis, moderate data, or moderate risk. So I just want to make sure that this is important to see how that would get to a level 4. A level 5 would be extensive for those, and these areas must be met. Anyone that wants to get this can download this on the FASMA webinar website. So I just wanted to go over that real briefly. So let me get out of that screen. And now I want to go over what's called test appropriate. As many of you probably know, we've talked about this before. We're just getting this up and running. There's going to be an icon located on your desktop called Test Appropriate. This is coming very quickly. I just contacted Peak yesterday to get this added to everyone's desktop, so it should be available very soon. You'll also be provided through Regina Morano, our compliance attorney, login information regarding your email address and password. This should be coming to you as well. Here's how this works. You will log in. Obviously, gotta wait for the website, and here we go. So this is for patients that we are going to refer who are Medicare only patients that we want to send for an MRI, a CT, or a nuclear medicine scan. Those are the 3 test reasons that the appropriate use criteria, also known as an AUC, is required by CMS, and technically it's required in 2020. So we're going to click on musculoskeletal at the bottom, and then you got to pick one of these 6 reasons. So let's say the reason the patient has pain. If the patient has pain, we're going to pick the area of the body, which is the foot. And then we're going to pick, is this an acute issue or a chronic? Let's say this is a chronic foot pain issue. The next thing is you have to pick one of these 3. Typically, you're going to pick that an x-ray was unremarkable or equivocal. So meaning, again, that you have taken an x-ray and you couldn't see what was going on. The next thing is you have to pick one of these reasons for this. So I'm looking for a patient who's posterior tibial tendon issues. I'm worried about a possible tear, so I'm going to pick tendinopathy suspected. The next thing we have to do is then pick the reason why the MRI is necessary, because we're going to want to pick an MRI. In this case, they're telling us that it's usually appropriate to pick for these reasons an MRI without contrast or an ultrasound of the foot. They're saying it may be appropriate for an MRI with and without contrast, and it's not appropriate to pick a technetium scan or a CT scan of the foot for these reasons. These are the options that we would pick. In this case, if I want an MRI for the foot without IV contrast, I would pick that. And now it gives me a criteria evaluation, which is usually appropriate. If you notice, there's an evaluation number that's assigned to this. There's a G code assigned to this. And this is the information that has to go to the radiologist. You would click continue, and then you're done. And then what will happen is this gets printed out. We would want this information scanned into GE, just like any other test. And the patient would have to be provided a copy of this to take with them to the radiologist when they have it scheduled. Right now, as you can see, it has my name as the provider. The address will have to have my office address. This is being updated. It's not been changed yet. And the phone number will be updated to be your phone number. So again, this will be set to your name when you log in, and should be able to provide this information. If you notice, you're not sharing any PHI information about the patient here. This is the best part about this. So no worries about PHI. It will have your name at the top. It will have your NPI number down here. and it will say that you've met the criteria for an MRI of the foot without IV contrast. Again, this is something that's important. This is a CMS directive. This is not something that we're making you do with FASMA. Unfortunately, this is just something that all providers, whether you're a podiatrist or an orthopedist or whoever, if you're ordering an MRI, CT, or a nuclear medicine study, you're going to have to go through these windows to create this. As you can see, it can be created pretty quickly, and it's able to be printed up and scanned in the patient's record, and also a copy given to the patient so they can take it to the radiology facility. And that goes over test appropriate. When you're done, you just log out, and then you're done with this scenario. So this is something we'll do again only for Medicare patients, not Medicare Advantage, unless we're instructed to do so. Only Medicare patients going forward if you're ordering an MRI, CT, or a nuclear medicine study. So let's jump into the educational program, and I'm going to turn this over briefly to Barbara so she can give her educational CME Online information.
Thanks, David, Dr. Friedman. My name is Barbara Bellioni. I'm the Continuing Education Coordinator for CME Online. Welcome to tonight's webinar, FASMA News, Notes, and Compliance, number 54. The learning objectives for this webinar. At the end of this program, you should be able to provide a proper response and actions if a patient sends a demanding letter. You should be able to understand the risk of cloning and how to avoid cloning to improve documentation in the patient's medical record. You should be able to discuss the appropriate use of advanced beneficiary notices. You should be able to improve compliance with CMS rules regarding billing DME outside your office. You should be able to understand and implement the 2020 Cigna requirement for CT and MRI. And you should be able to differentiate between an unrelated procedure modifier and a global modifier that is used when another procedure is performed. Tonight's speaker is David J. Friedman, DPM. Dr. Friedman received his Bachelor of Science degree from Syracuse University, followed by his Doctor of Podiatric Medicine from Temple University School of Podiatric Medicine. He did his residency in surgery at Kessler Memorial Hospital in New Jersey. He is currently Vice President of Foot and Ankle Specialist of the Mid-Atlantic and a board member of the U.S. Foot and Ankle Specialist. He is a past president of the Maryland State Board of Podiatric Medical Examiners. He has been active nationally as a committee member and now chair of the American Podiatric Medical Association Coding Committee. He is the CAC representative from Maryland. He is board certified in foot surgery by the American Board of Foot and Ankle Surgery and is a fellow of the American College of Foot and Ankle Surgeons, a fellow of the American Society of Podiatric, and a fellow of the American Society of Podiatric Surgeons. He is certified from the American Academy of Professional Coders and is a certified professional medical auditor. In accordance with the Council on Podiatric Medical Education Standards, Requirements, and Guidelines for the approval of sponsors of continuing education in podiatric medicine, any relevant financial relationships with commercial interests of faculty, planning committee, or any others who have influence over the content of this educational activity must be disclosed to program participants. Neither the speaker nor the planning committee have any financial relationships to disclose. CME Online is approved by the Council on Podiatric Medical Education as a provider of continuing education in podiatric medicine. CME Online has approved this activity for a maximum of 1 continuing education contact hour. At the end of this webinar, you will receive a post-test. Please complete the post-test and return it. You must score at least 70% in order to receive a certificate of attendance. If you have any questions during this program, please type your question in the question box on the screen, and Dr. Friedman will answer them at the end of the program. Also, please note that there is an evaluation form in the handout section of your screen. Please complete the evaluation and return to me at the email address listed on the form. Now, I will turn the program over to Dr. Friedman.
Thank you, Barbara. And thanks, everyone, for being on the webinar. I hope everyone got something out of the first 7-8 minutes of this with the test appropriate and with the overview of E&M for established patients. Again, we have to show that there's no conflicts of interest and no off-label issues. FASMA news and notes, just so you can update your schedule again. You should note that you have the May 7th, 2020 webinar. We have that coming up, and then July 8th will be the next one after that. And of course, we'll have to assign one going past there. We'll figure that one out later on. Again, this is a educational webinar as Barbara related. You need to pass the CME approved test at the end for 7 out of 10 questions. It's in electronic format. You will get that at the end of the quiz once we end the webinar. Please don't close out the browser because it should automatically convert so you can do the webinar quiz. If you do not receive it, another email should come tomorrow. And at that time, you should be able to do the quiz then as well. If you still do not receive it after tomorrow, please email me, and I'll be more than happy to send you a second supplemental type of quiz that you can do, which mirrors this quiz that you should have gotten at the end of the webinar. Everyone has access to Coding Resource Center. If you have any questions about a HCPCS code, about a CPT code, about a diagnosis code, obviously things are in GE and they're at your fingertip, but if you're not sure, you can search things here. A great way to search also is if you're doing any edits, you want to see which one is primary versus secondary, your CCI edits are there, and this helps you dramatically. Our website is, again, the APMA Coding RC. Our user ID is the FASMA ID, and the password is Goody1600 as listed here. And our secret word, if it asks for you, currently is Rockville. This is available to you on the GE desktop of any patient's chart as well, and you just click on that. It should take you here. If you're current with our FASMA webinars, we've completed 53 of them. If you missed one, you probably missed something that's very important information. So please go back and look at some of the most recent ones, especially our newer doctors and newer practices, so that you can see how we function as a company and as an entity to keep people compliant and meeting the rules of the world we live in. Today's webinar, again, is Barbara related. It covers about these 6 things. We're looking at patient engagement. We're looking at cloning, ABNs, providing patients with DME and supplier outside offices, and understanding how to get patients approved for medically appropriate imaging services now with Cigna, besides what I showed before with CMS, and documentation unrelated procedures during the global period. So we'll talk about that as well as staged procedures. So a patient sends us this type of letter, answers needed to possible malpractice lawsuit pertaining to misinterpreted MRI dated 10/24/19. Would this treatment plan for my current condition be different? If you would have known exact findings 6 weeks sooner, how would the future treatment plans for my current condition be different if you would have known exactly findings 6 weeks sooner? And what impact did this 6-week delay have on my overall health and my future health? You know, when we see things like this or anything that's accusatory to you, you don't immediately respond to the patient. You have to send this immediately to Regina Morano, who's our attorney for the in-house compliance as our attorney, and let them look at the letter, decide what they want to do as to how to act on these things. You don't engage the patient. You don't discuss these things with the patient. It's best for you to say nothing about this. The patient to say, we'll have to get back to you if somebody even asks you in a phone call or a phone conversation. So this patient requested that our doctor provide these written answers. And, you know, you really have to look at this and say, you know, was it an issue? Could there have been a delay with the radiologist reading an MRI and how it could have negatively impacted our patient? The reality is that, look, the bottom line is that, you know, we don't want to be involved in a pissing match with a patient and another provider. It's best that you provide them the information that you have, although you can provide them with maybe an MRI report. But when they start sending letters like what you just saw here, it's very important that the involvement of our compliance attorney is involved. So don't respond, Chief Legal Compliance Officer and attorney, and that's the best thing. And we may have to involve our PICA policy people as well as outside counsel provided by PICA if it's necessary to help draft a letter to a patient like this. So we will respond to the patient, but we want to do it in a very compliant manner and not involve you or cause you to be at risk. Things you need to know and what to do and not to do. So here's something here. I've reviewed the letter provided during the visit on X date, and unfortunately will not be able to respond to the legal questions you've outlined. My focus is entirely on providing you with the highest quality health care and supporting your progress rather than on legal issues you may perceive related to an outside testing. This is basically a basic 2-paragraph thing that the patient would have received just to show them that, hey, this is something we don't want to get involved with. And I am happy to review with you any questions about your medical condition and the care I'm providing in the context of your ongoing treatment. So that, again, you can provide information that's pretty generic, but not get you involved in this issue that the patient had with not getting their MRI for some period of time that was not related to you. Next, I want to talk about cloning documents. We call that copy and paste. And just to let you know that obviously we review a lot of records. So far this year, reviewed, besides myself and Fong and our compliance doctors, probably almost 500 records so far. So we look at a lot of stuff, and one of the issues that come up often, not only that we have seen, but is seen obviously nationally, and here's just an article that was written recently in AAPC's magazine about the dangers of clone notes in healthcare. So clone notes is anything we copy forward. If you say something, do something that looks exactly the same as the previous visit, then that's not new medical decision making. It's not new information. And the carriers, the health insurance companies who pay for these visits that you want to bill for will ask for these notes. And if nothing changes or looks different, then you don't get credit for that on the future visit. So just because you see the patient, you spend time with the patient, you don't document things well that was specific to that date of service, then clearly that puts you at risk for being potentially using clone notes. So I just wanted to make this aware to you because a lot of people like to copy and paste things going forward. You have to make things look different. This is the Office of Inspector General, the OIG, and this is dating back to 2013. And clearly OIG made it clear that copying and pasting, also known as cloning, allows users to select information from one source and replicate it to another location. What they're concerned about is that this information is inaccurate when you keep bringing it forward. It brings inappropriate information forward. It copies things that are irrelevant to the visit that day. And these are things that they consider to be inappropriate to do. So understand from the compliance side that we have to look to see sometimes when there is potentially cloning going on. If we are, we're going to say something to you that this note looks no different than the previous note, so you may not deserve to get paid for that E&M visit you're billing today. You have to be very relevant to what you're doing that day and make sure that it's not something that's cloned. This is from the MACs, Medicare Administrative Contractors in our area. The two are Novitas for our area up here in Pennsylvania, DC, Northern Virginia, Maryland, and then of course Palmetto, which would be Virginia and North Carolina. But clearly you'll see here, this is information that's related by the several MACs. So you'll see Palmetto in here as an example. But again, when it comes to your documentation, documentation has to support the services rendered to be paid by the specific payer on the date of service. You can't use generalizations. You have to be specific. You have to get credit for things that you did that are relevant to the patient's care that date. And it has to be specific for that date, not for carrying forward things before. So again, this is just kind of a overview article about which carriers have already related this. And certainly one of the ones in our area, which is Palmetto, has made it specifically informative in their website about these things. To ABN or not to ABN, I've seen that as a question, so that's, I thought, a great opportunity here to jump in about advanced beneficiary notices. We have patient scenarios where the patients come in and we saw the patient who's a Medicare patient, and is he diabetic but did not meet the class findings? What do? You want to send this to Blue Cross Blue Shield. They deny it. Can we bill the patient, not bill the patient? Should we have an ABN? What is overall that's going on with these patients? And the reality is, when we see with routine foot care as an example, remember that routine foot care is statutory not covered. Anything that's statutorily not covered technically does not require an advanced beneficiary notice. You can do one, but just because the patient's a diabetic but they have no class findings, then that may be the case where you want to say, hey, this patient has a systemic disease that may be covered under the service, but because they don't have the class findings, that maybe you do want to have an ABN on file. They don't have to have one if it's statutory not covered. And when we see patients with the statutorily not covered services, we would put on the CPT code, the GY modifier. The GY tells the payer that this is statutorily not covered. This is written into law that this should not be covered come hell or high water. Now, there are statutory non-covered services, and other insurances sometimes may pay for it. We don't want to worry about that too much unless we know for sure that the patient's insurance secondarily may cover the service. We typically want to use our internal coding. We provided you with the A90-160 and the A90-270 versions for billing at-risk or non-covered routine foot care. And this way, we don't have to worry about collecting it, through billing services and sending to insurance. This is something that's point of service collection. You collect this at the front desk. If you provide the service that day, that's going to be a non-covered service. You make sure you tell your front desk that this patient's service is not covered. You tell the patient that when before you touch them, you cut something or do something, the service is not covered. You're going to pay for this on the way out. And then you make sure the front desk staff collects the money on the way out, as we should not be billing any insurance or billing the patient for these services. Can I execute an ABN for routine foot care is the next question. And the answer is you can. Again, it's not mandated, but it provides the patient with education to understand their treatment is not maybe covered, or it's maybe covered, but they're seeing the patient too soon. Some patients are covered for foot care, for example, and they are at risk, but they want to come every 5 or 6 weeks. Those patients in between would normally be covered. So because they normally would be covered, would be requiring an advanced beneficiary notice, and then we'd want to use our ABN that we have. So just to make sure they understand when and when not to use an ABN, again, for routine foot care, technically, again, if it's not a covered service, it's statutory not covered in this case, an ABN is not mandatory. It just gives you that extra piece of paper if you really want something to go back to hang your hat on that I told the patient it was not a covered service. So billing staff advice, is it okay? The doctor submitted 11056 GY, 11720 GY on a certain date. The staff commented they should not have billed it. It was factually incorrect. The patient wanted to get to the secondary payer like Blue Cross Blue Shield. So we're not sure what the staff was looking for. The patient desires to be billed because they have a secondary. Then it was billed correctly with the 11056 GY and 11720 GY. So again, this is a scenario where a patient says, I want you to bill my federal Blue Cross Blue Shield plan. And then if they have potentially coverage, it may get covered as long as it meets the policy of that plan. Again, we try not to bill these, but the patient has to understand that this is our fee, and it's the full fee that the patient would be responsible for. So in these cases where we bill these two fees, I believe the fee is around $200. So instead of paying like $70+ for the A90 160 and $84 for the A90-270, technically the patient's responsible for our full fee when we bill the full fee and it gets denied by Medicare. It says PR 96 for patient responsibility, and then it goes to the secondary and it says PR whatever for their response, means patient responsibility. Technically the patient becomes responsible for the full fee, not the discounted fee. So just make sure your patients understand that they're responsible for the full fee, not the discounted fee, if they want to put this through the insurance like this. So what did the EOBs show? So if we have a Medicare EOB and it has PR 96, if you ever look at an EOB, and the way you can do that in GE, you look at the dollar sign, you go into the patient's history and records, and then there will be scanned documents in the patient's scanned documents. And there'll be EOBs there, and you can look up by patient. So if it's a PR 96 for a patient, that means it's patient responsibility, because a GY tells the payer, like Medicare, it's statutory not covered. And if it's statutorily not covered, you don't have to have an ABN on file, even though some people sometimes think you do. It's not mandated. It is not necessary. It's nice to have it, but it's not necessary. And in this case, we saw Blue Cross Blue Shield had the EOB. It said PR 23, patient responsibility, which means, again, the patient was responsible for this ticket. And then technically the full fee was available. And here's the example, that $211 would be the responsibility of the patient because they made it submit it to the insurance. They didn't submit the insurance, our discounted fee of A90-160, A90-270 would have provided them with a deeply discounted fee relative to this $211 that would be required because we billed the full CPT codes to Medicare and then to Blue Cross Blue Shield. So patients need to understand this, that by doing this, it's at their own risk. They're going to pay more for the service because they required you to send this in. So make sure you understand that this is an option that you have. I would tell the patient, I know it's not covered. Your Medicare and Blue Cross Blue Shield is not going to pay for this. You pay the fee today. If you make me send it in, you're going to be responsible for our full fee. It can't be discounted after the fact. So make sure the patients understand this. And last, an ABN is used to for covered services. So if it's covered at-risk foot care, as I mentioned earlier, the patient wants to come in every 5 weeks. So we know that if they come in less than 61 days, it's not covered in that service. But in the case where it is a covered patient, technically you have to have them sign an ABN because it would be otherwise covered during that service. And my recommendation, again, is always to use our A9160 or A9270 for those in-between visits so that the patient doesn't have anything submitted to insurance. We have them sign an ABN in case they do make us turn around and bill that to insurance. All right, here's a new one. Federal Blue Cross Blue Shield CPTs 11/7/20, 11/7/21. It says that manual debridement, electronic grinding procedures of toenails when performed by a qualified provider are considered medically necessary only for onychomycosis, mycotic nails, when confirmed by positive culture or by documented signs and symptoms. So, for anyone that treats our federal plan Blue Cross Blue Shields, which a lot of us do, whether it's in the DC or outside that area, I'm sure you see federal people in Charlotte and Raleigh and Virginia and wherever else you practice in Pennsylvania, DC, Northern Virginia, whatever. So here's the deal. So if you're going to bill this, you better have good documented signs and symptoms, why it's medically necessary for these onychomycotic nails, or have it confirmed by a positive test culture. So these are the rules that I picked up recently when I was doing a review for the federal Blue Cross Blue Shield policy on the Blue Cross website. Routine foot care for federal Blue Cross Blue Shield. This is, again, generally not considered medically necessary. They will consider it for patients who have systemic diseases, metabolic, peripheral neurological, and peripheral vascular disease, as just like Medicare. So this is kind of similar to what they say there for Medicare for covered foot care on the federal Blue Cross Blue Shield site for routine foot care. I'm going to jump into Cigna for their radiology requirements that go into effect April 15th, 2020. We obviously see Cigna patients throughout the area, and it's important to understand that they have now new criteria similar to what Medicare is doing, in this case for MRI and CT scans. So if you look to the side here, you'll see that the pre-certification requests include freestanding and facilities in accordance with the terms of coverage of the policy of the patient. This is for use of outpatient setting only, so it's not obviously for inpatient requests. They are requesting that pre-certification be done through this EviCore Healthcare by logging into EviCore. So you need to get pre-certification through your office staff for Cigna patients for either CT or MRI starting April 15th. This is mandatory if you want to get patients those special radiology tests. So you can see this, the writings on the wall where more payers are going to be limiting MRI, CT eventually down the road, like Medicare is trying to do with the this year trial period, which becomes mandatory by January 1st of 2021. And now we have the Cigna health insurance requiring this as well. So important to understand that. So again, please make sure that you go to the Cigna for a health care plan. That's the Cigna forhcp.com. If you've never logged in, you should have access, your staff should have access to the website so they can do this. They have to look at the high-tech radiology site for this, for the coverage policy that's listed here. They actually sent out notification as far back as December, but the policy goes into place April 15th, so it's coming up pretty quickly. And last, these are, again, the websites, evicore.com, and it's /resources/health plan /Cigna, and they have an 888 number 693-3297. So any of the docs on here that maybe see a lot of Cigna patients, make sure your staff has this information, and it should be available to anyone that looks at the Cigna for Health Care Plan website as well. All right, let's jump into something called Modifier 58. Modifier 58 is a staged or related procedure by the same physician during the post-operative period. So this is used usually in the global 90-day period that means that you're going to do another procedure or service in that post-operative procedure. So staged obviously means you're anticipating that you're doing more surgery. You did debridements for a diabetic who has gangrenous toes. You debride some toes, you yet didn't do a full amputation. You would document in your op report that this is a staged procedure, meaning you're going to do the debridement as much as you can do at this session, but there's a good chance you're going to come back in the next day or two or the next week and do additional revisional procedures. That's staged procedures. Sometimes you have to do something that's more extensive than the original procedure, or therapy following a surgical procedure is the other reason it says here. The circumstance has to be reported with modifier 58 when it's staged or related. An example of a 58 modifier, again, would be here, is you did a surgical procedure 2 weeks ago, and it has a 90-day global service. You're performing a debridement today, 11042. 11042 has a 0-day global, but you're doing this new surgical procedure in the 90-day window. And because you're doing it in the 90-day window, that requires you to use the modifier 58 when it's related to the previous procedure. If it's not related to the previous procedure, you'll be using modifier 79. There's also something called modifier 78, which is an unplanned return to the operating room procedure in the postoperative period as well. People don't know this, but there is actually a payment reduction requirement in modifier 78 procedures. So it's usually better if you can conform to modifier 58, because modifier 58 gives us the ability to get paid the full surgical fee for your surgery in the global period. So some people know this, some people don't know this, but I thought this would be a good thing to point out when it comes to payment, because a lot of us want to get paid for what we do. Again, modifier 79 is saying this is an unrelated procedure in the global service period. Again, this means that the procedure performing today is not related. It's on a different anatomical site. It's a different foot. It has to be a different site or location. It can't be the same specific site you did another procedure. So let's do a simple procedure like here. We're doing a partial matrixectomy of a great toe, left great toe, 5 days ago. The patient presents back today for another 11750, but now for the right foot. The T5 means today is the right foot. This is the global period because it's got a 10-day global period. You must put modifier 79 on the 11750 T5 in order for this to be paid, because this then says it's an unrelated procedure. So the proper billing for the second procedure, because it's done within the 10-day global window, is the 11750 T5, saying it's a different toe, it's different anatomy, and modifier 79 tells the payer that this is unrelated. So let's see here, what was wrong with this procedure that we found when we did a review? So clearly the doctor documented that the patient had cutaneous abscess of left foot. That's L02612. You'll see the diagnosis above. But then we'll see that 10060 was documented on 3 different lines. Now, in case you don't know about 10060, that's a simple incision and drainage of an abscess, or uncomplicated one. It only is to be used on one toe. If we do multiple INDs, that becomes 10061. There's no reason to put any other modifiers on these. You don't have to put left or right. The payers automatically know it's single or simple for 10060, or it's multiple or complicated for 1061. 1061 is 10, and 1060 tend to be skin-related abscess stuff. This is not your deep abscesses in the foot. If you're using it for deep abscesses, it's the wrong code. You'd be using the 28000 series, which is usually the 28001 through 28003, for example. But I just wanted to show where we see, and we do audits with patients, billing, and we see what doctors did, and somehow we got multiple billing for the same code, which should never happen. So it's just important to see when you have an abscess, you're doing multiple ones, it's simply just 10061, no lefts, no rights, no excesses, no T5s, it's one code. Here's another one. Patient had ingrowing nails. And oh, by the way, when you look at the diagnosis pointers here, you'll see sometimes multiple diagnosis pointers. The insurance only needs one primary diagnosis. So you pick the best diagnosis for 99% of the things that we do. If some do require secondary diagnosis, then go ahead, we'll have you put that on. But relatively, what's the most primary diagnosis here? So if they have an ingrown toenail, that's the reason we're going to be doing the procedure. But again, let's look at this one here. So the doctor decided to do multiple nail avulsions. So we have 11730, 11730, we have 11732. How does this work? So with nail avulsions, if you're doing multiple nail avulsions, the first nail avulsion is always 11730, and you would put the toe modifier like was done here, T7. Any subsequent nail avulsions are never another 11730. You only use the add-on code 11732. And then you'd put the number of units that you avulse. So if you avulse 3 different nails in addition to the first nail, the quantity would be 3 as the units. And then you just would then document which modifiers were those 3. So if it's T6, T5, T4, T3, whatever, you just mark which toes are the additional ones. And of course, 11732 on one line gets you up to 4 modifiers that you can use. So you can do up to 4 additional nail avulsions in addition to the first one on the same billing for 11732. If you did another 11732, meaning more nail avulsions, which is kind of rare, then you would start a second line for 11732. So this just shows, again, just showing on audit, when we look at billing, how things come back to us, things get bounced by the insurance carrier because it's just not billed right. So important to understand avulsions. R26.9, unspecified abnormalities of gait. This code is not the proper code to use ever, period. You can use this in the diagnosis tree if you really want a gait abnormality diagnosis. Just put it in really your musculoskeletal exam. You don't need this diagnosis or any R diagnosis because most of the stuff we do has a specific diagnosis. For diabetic shoes or for anything that we're doing, the diabetic diagnosis is what goes with diabetic shoes always, never any other diagnosis. You don't put down hammer toes, bunions, deformity of the foot, whatever. You do not use our diagnosis. You don't do other diagnosis. The only diagnosis for here would have been, for example, an E11.51 for a type 2 diabetic patient who has vascular changes, or a patient who has E11.42, which is a type 2 diabetic with polyneuropathy. One diagnosis, one for each of those diabetic conditions. The next thing here, which is interesting, is the AFO diagnosis and AFO procedures. An AFO is fixing a structural problem. So this is usually for an acquired problem more than a congenital problem, but it can be for both. Typically, we're making an AFO because they've acquired an issue, and that's what you're using it for. So, of course, that one diagnosis would be appropriate and pertinent here. Again, not using the R diagnosis. Otherwise, the billing for the A5500, A5512, 11, 19, 40, 23, 30, and 2020 are appropriately to be billed with KX modifiers. And whether you do it left and right, that means you're doing 2 units, one for each side, one each extremity. But again, the diagnosis is key. We got to pick the most specific and the proper diagnosis in these cases. Don't forget your prescription button. Notice recently that some people are forgetting about the RX renewals in GE. If you look at the far left here on the side where it says desktop, chart desktop, that's where you get whether there's flags, alerts, documents, but there's also your prescription renewals. So if you have any prescription renewals, they'll show up here. You're supposed to act on them. So either allow them or deny them. If you deny them, you put a reason why you're denying them. If they show a patient at the bottom that's in yellow, like you see here, or that kind of offset yellow color there, that means the system cannot identify the patient specifically. So where it has the person head, you click on that, and it gives you the ability to search for that patient and see if that matches another patient in our database. So very important, don't forget about your prescription renewals. They do show up here, and they may be sitting in your box. You may not have any idea that they're sitting there. Please don't forget them. So here's how it looks, RX renewals. Click on that button, and that's where you go. Okay, we're at this point in time in the webinar today where we're ready for any questions and answers. Barbara, do we have any?
We do not have any currently, so we can wait just a little
Anyone a
bit.
chance?
What?
This gives anyone a chance who wants to ask a question to ask a question about what's presented.
Okay, wait a minute, we have one. Hold on.
We'll give another minute here if there's any questions. If not, we'll then proceed to the Q&A part of it.
Okay, we do have one.
Okay.
The L1940 sounds like a more balanced brace. What is appropriate?
So when we have a more balanced brace, it usually has to do with the patient has an acquired deformity. The recommendation is use a musculoskeletal diagnosis. Typically the most common one that's used for this, because it's a kind of grab bag universal for anything wrong with the foot, is M21-6X1 and M21-6X2 for the right and left foot. That should be a musculoskeletal diagnosis.
Okay, I do not see any more questions. So I guess that ends our program. Thank you so much for listening. And Dr. Friedman, thank you so much for your presentation.
Thank you again. And we'll see you again in 2 months.
Okay, bye.
Yep. Wait for your quiz, everyone.